Hello, everybody. Dr. Condor. We're going to talk about Chapter 5, which discusses genes, the environment and lifestyle, and those common diseases. In class, we will, or maybe you're listening to this after class, Chapter 4 talks about diseases that are caused by either a single gene or some abnormality of a single chromosome. Now, these conditions only form a portion of the total burden of human genetic disease. And we know that the congenital malformations are usually not caused by just one bad gene or one chromosome defect. Things like cancer, heart disease, and diabetes, all of these have genetic components, but they're usually not caused by one single gene or one chromosomal abnormality. All of these are a result of a complex of interplay of multiple genetic and environmental factors. And that's one reason why it's so hard to treat high blood pressure and obesity. How do we know how many people have diabetes and how spread it is? We use two different rates. We have the incident rates, which is the number of new cases of a disease over the number of individuals or the total population, okay? I know that's not very good writing. Total population over, and this specific period is usually within a year, okay? So that's our incidence rates. The number of new cases of a disease divided by the number of individuals in the population. Now, prevalence rate is different than incident rates. Prevalence rate is the proportion of the population that's affected by disease at a specific point in time. This can vary from population to population, and it could be the prevalence of chickenpox at a certain time is less than chickenpox at other certain times. Now, the prevalence rate of, say, something like HIV or AIDS is going to be different than the incident rate because the incident rate is the number of new cases. The prevalence rate is probably going to be higher because the people with HIV and AIDS are living longer now. So it would have a higher prevalence rate than maybe an incident rate, or we hope anyway. Now, I said that these diseases can vary. Prevalence can vary from one population to another. The book gives you the example of cystic fibrosis and sickle cell anemia. Cystic fibrosis is much more prevalent in the European nations, whereas sickle cell anemia is more prevalent in those African Americans. So the prevalence rate can vary. When we talk about risk factors, a common measure of the effect of a specific risk factor is the relative risk, and this is usually expressed as a ratio or as a fraction. So when you talk about the relative risk, it's the increased rate of disease among the individuals that are exposed to a risk factor divided by the incidence rate of the disease among the individuals that are not exposed to a risk factor. So the book gives you an excellent example about how they figured out the relationship between smoking cigarettes and lung cancer. It compared the incidence of death from lung cancer in those that smoked versus those that did not. And the incident death rates from lung cancer was like 1.7 per 1,000 person years in heavy smokers, but it was 0.07 in non-smokers. So the ratio of these two incidence rates, okay, new cases in the population, is 1.66, so it was 1.7, 1.66 divided by 0.07 which is a fraction, and that's going to give you a relative risk of 23.7. So you could say, and that's a point there, that cigarette smoking increases your risk of lung cancer 24-fold. So that's your relative risk. Now, so far we have talked about three different measures: the incident rate, the prevalence rate, and the relative risk. Incident rate is the number of new cases divided by the population. Prevalence rate is the number of individuals that have the disease divided by the number of individuals that do not. The relative risk is the number of the rate of the individuals that have the disease and were exposed to the risk factor divided by the incident rate of those who were not exposed to the risk factor. I would make sure that I knew those three. I am sure that you all know what risk factors are. There are many: your age, your gender, your diet. We all know that women are at greater risk for breast cancer than men. It can happen in men though. Your diet and exercise can make you susceptible to diseases or not. Family history of disease, all of these things can increase the risk. And there's so many complex interactions between the genetic and non-genetic factors. And if you're listening to this before lecture, we'll talk about some of those things with epigenetics. And if you're listening to it after lecture, I hope that you're making the concept key there, in that the environment can turn off or on some of your genetic determinants. All right, now, so when you think about multifactorial inheritance, you have your polygenic traits. Polygenic are the effects of multiple genes that cause the variations in the traits. Okay. Multifactorial traits are environmental factors that cause various traits. And then quantitative traits are traits that follow that normal bell curve. And these are measured on the continuous normal numeric cycle. And again, they follow that normal bell curve. That'll come into play in just a second. So, riddle me this. Which information is correct regarding relative risk? And I'll give you just a second to read that. What does relative risk indicate? Okay. So hopefully you put that the relative risk is the chance of developing a disease relative to an exposure. Okay. The first one is wrong. The number of new cases of a disease in a specific time period, that's the incident rate. Okay. Because remember, that time period is usually 1 year. The proportion of a population with the disease at one point in time, at one time point, not time period, is the prevalence. And then number 3 is the correct answer. The ability of a causative factor to produce a disease, that is pathogenicity. Okay. Okay, now we'll talk about the liability distribution with this threshold model. This does not follow that normal bell-shaped distribution, and it either appears to be either present or absent in individuals. It also does not follow the inheritance patterns of those single cell diseases or single gene diseases like we talked about with chapter 4. And when you think about the bell curve, and there's a picture on the next couple of slides, you have the low end of getting the disease compared with the high end of getting the disease. So it's almost like when it reaches a threshold, then the person gets the disease. That's what it seems like. That's not a scientific explanation. And this will play out much better on the next slide that has the picture. But below this certain threshold, the patient appears normal. And then when they get above the threshold, this is our bell curve, and say this is our threshold. So everybody from here back appears normal. And then from here up, the patient would have the disease. Now, the book gives you the example of pyloric stenosis, neural tube defects, clubfoot, some forms of congenital heart disease. See, here is the liability distribution, and this shows that threshold for males and females with the pyloric stenosis. So at the point an individual accumulates so much liability, they're going to be affected by the disorder. Okay, that's the threshold level. Individuals that have affected relatives have a higher chance of exceeding the threshold and thus being affected. All right, now reoccurrent risk. Reoccurrent risk is hard to determine, especially in those multifactorial disease. You may have a number of genes contributing to the disease and not know what those genes are. Also, you don't really know the allelic conditions of the parents or the extent of the environmental effect it can have on that patient. So we have what we call an empirical risk, and it's based on direct observation of data, and it can be pretty specific for each multifactorial disease. This reoccurrence risk can change. And again, we're talking about gene frequencies, environment, and lifestyle factors. All right, so some things to remember about the reoccurrent risk, and these will be written out. That's not very nice of me to put RR on there when we've got relative risk as well. But the reoccurrence risk is higher if more than one family member is affected. So if you have siblings, your grandparents, your parents, if they all have this certain disease, then your reoccurrence risk is higher. Now, if the proband is more severe, the proband being one of the parents that has the disease. Also, if the proband is one of the less commonly affected sex. For example, if you are a male and your father has breast cancer, that's not very common for men to have breast cancer. That increases the reoccurrence risk. Okay. Now, another thing about the reoccurrence risk is that it usually decreases rapidly in remote relatives. This is why we say that when we're talking about the breast cancer risk, it's really only a matter of the parents. If the mother has breast cancer, then that increases the risk of the daughter. If the grandmother had it, that doesn't necessarily increase her risk of having breast cancer. It might make the daughter be more cognizant, or the granddaughter be more cognizant of that, but the further you go out, so if great-grandmother had breast cancer, then the great-granddaughter, her recurrence risk would be 0. So that's important. Recurrence risk of the disease decreases rapidly in those remotely related relatives. Okay, so recurrence risk in multifactorial disease is higher if more than one family member is affected, lower if the disease is more severe in the proband, higher if the proband is the more commonly affected sex, or rapidly increased when more distant relatives are affected. Let's see what the answer is. And hopefully you said it's number one. Higher if more than one family member is affected, okay? So remember, the reoccurrence risk becomes higher if it's more than one family member. All right, so more than one, say if grandmother and mom had breast cancer, that would increase the recurrence risk. But if it's just grandma and nobody else, that doesn't, okay? Um, Now remember, if the expression of the disease in the proband is more severe, the reoccurrence risk is higher. Okay, and that is consistent with that liability model because the more severe expression indicates that the affected individual is at the extreme tail of that extreme tail end of that liability distribution. And remember, that's the one with the bell curve. So they would be at this area. Now, his or her relatives then would be higher for inheriting those genes. Now, the reoccurrent risk is higher if the proband is of the less commonly affected sex, okay? So the less commonly affected sex. And that's because the affected individual of the less susceptible gender is usually at a more extreme position, again, on that liability, on that bell curve. I know my bell curves aren't getting very belly, are they? Now, the last thing, or number 4, the reoccurrence risk for the disease usually decreases rapidly in the more remotely related relatives. Okay, the reoccurrent risk for a single disease decreases by 50% with each degree of relationship. But don't get into that, don't be that nitpicky about it. I just want you to know that the more distant the relative, the less likely, the less recurrent risk is. Okay, now we all know about nature and nurture. We have the nature, which is the genetics, and the nurture, which is the environment. And we try to study those to see if we can determine the relative influence. And when they do this, they do a lot of twin and adoption studies. And when you talk about twins, what I really need for you to remember on this slide is that if you have monozygote twins, those are identical, okay? And then dizygotic are fraternal, in other words, not identical. Now, if you have a concordant trait, that means both of the twins share the trait. A discordant trait means that they don't, okay? So if it's concordant, they share, discordant, do not, all right? That's going to come into play later. So when they talk about studies with these twins, usually you're wanting to compare the monozygote twins to the dizygotic twins, okay, or the identical to the fraternal twins, which is easier to see. Now, children are born to parents who have a disease, but then are subsequently adopted by parents lacking the disease are also studied for disease recurrence. Okay, so adoption studies. That helps us indicate how much of those genetic factors actually cause that multifactorial disease. And again, that gene environment interaction. You have your genetics of common diseases. I'll let you read that there. Now, these next few slides are going to talk about multifactorial disorders in the adult population. And I'm just going to point out a few things to you. Coronary heart disease. So with coronary heart disease, you need to know that the risk increases if there's more relatives that have it, If they're female, and if your mom has it, um, rather than male, that increases the risk. And if the age of the onset of that person is younger than the age of 55. Now, look at these things that also increase the risk. Autosomal dominant familial hypercholesterolemia. Autosomal dominant, for those of you watching this prior to lecture, that means the person only has to have one gene in order to express the disorder, okay? So if they've got that one gene, they're going to have familial hypercholesterolemia. Now, if you add that with the high-fat diet, not exercising, put smoking on that, all of that's going to lead to obesity, and that's going to increase the risk. So the things that you can change, or that your patient can change, is that high-fat diet. They can exercise and stop smoking, and hopefully that will help with their obesity and thus decrease their risk. All right, with hypertension, we're going to talk about this too when we get into health assessment. Hypertension is a risk factor for heart disease, stroke, and kidney disease. That's why you need to look at their heart, their brain, and their kidneys when they come in to see you. Now, it's important that when you have somebody that has high blood pressure, that they know about their environmental factors. That's their sodium intake, their lack of exercise, stress, and obesity. All of that increases their risk factors of hypertension. And again, when you start talking about the RAS system in patho, when we get to it in patho, blood pressure regulation is very, very complex. Now, cancer is the second leading cause of death in the United States. There are several different types of cancers. Most of the cancers do run in families. So we already know that smoking causes cancer. Tobacco, whether it be smokeless or smoking, accounts for 1/3 of all cancers. That's pretty significant. Now, breast cancer, the recurrent risk increases if the age of the affected relative is early. Okay, so if the mother had this breast cancer early in life, premenopausal, and if the cancer was bilateral. Now, we know, again, an autosomal dominant form has been linked to chromosome 13, and we know that that causes a 50 to 80% lifetime risk of developing breast cancer. And it also increases that risk for ovarian cancer. So if the patient has that autosomal dominant form, BRCA2 or BRCA1, that substantially increases their risk for breast cancer. I would know those genes. Okay, chromosome 13 and 17, BRCA1, BRCA2, mainly just the BRCA1 and BRCA2 increases the risk of breast cancer, and that they are autosomal dominant. All right, colorectal cancer. Again, colorectal cancer clusters in families. And this has to do with this APC gene mutation. And so you get some polyps in there, and then there can also be some somatic mutations. And then the environmental factors that increase the risk of colon cancer include a high-fat, low-fiber diet. So we need to have a low-fat, high-fiber diet to help reduce our risk of colon cancer, colorectal cancer. Now, prostate cancer. Of course, this occurs only in men because only men have prostates. The high fat diet is a risk factor, and prostate cancer, can be detected by digital examination and a prostate specific antigen. Recommend doing both. But again, when we start talking about evidence-based practice, you'll want to make sure that you're keeping up with the latest guidelines on the United States Prevention and Task Force. All right, so for cancer gene identification, there are hundreds of genes that are mutated in various cancers. Some are considered the primary causes of cancer. You have and those are driver genes. So if they're driving, they're going to be in charge. Those are the primary causes. And then you have these passenger genes that don't directly have to do with the growth advantage to those cells. We already know that diabetes is very complex and not fully understood, and these are two major types, but there are more. The thing with diabetes is that it is the leading cause of blindness, heart disease, and kidney failure. So when somebody comes in to check their diabetes, you need to check on their eyes, their heart, and their kidney, okay? It's not just about their blood sugar. So we know that type 1 diabetes is an autoimmune destruction of some insulin-producing beta cells. These guys are going to need insulin forever. If you have a sibling that has type 1 diabetes, chances are you're going to have that could increase your risk of diabetes. And if your father was a diabetic, that also increases your risk factor, type 1 diabetic. Now, again, there are more than just two types. You can also have a late onset autoimmune diabetes. That's not going to be on your test, but just know that it's there. Now, type 2 diabetes, more than 90% of people that have diabetes actually have type 2. This is usually not from autoantibodies. This is usually from insulin resistance or insulin production is diminished. If the patient is obese or they have a positive family history, this is why it's important to get that family history. That increases their risk. Exercise does have a preventative effect. So identical twins have a 90% risk, and then the first degree relatives have a 15 to 40% risk. Again, type 2 diabetes, there is a variation of this gene that's associated with a 50% increased risk. We all know what obesity is. Body weights of the adopted individuals do correlate with their natural parents' body weights. We do know that genetics have effect on body weight, and that there is a gene for leptin and its receptors that are related to obesity. When you talk about obesity, it gives you a substantial risk factor of the things that we've already talked about: heart disease, coronary artery disease, prostate, colon cancer, breast cancer, and type 2 diabetes. Alzheimer's disease, I just want to point out a couple of genetic things on here. If you have a first degree relative that has Alzheimer's disease, that is going to double your chances. There's also mutations for early onset. They affect that amyloid beta deposit. The thing to remember is that these genes right here, the presenile genes, PS1 and PS2, and the APP, amyloid beta precursor protein, these are the primary cause of Alzheimer's disease. Okay, so if you see pre-senile, then make sure that you think about the cause of Alzheimer's disease. Alcoholism, 3 to 5 times higher if the individual has an alcoholic parent. Something that's interesting are these twin studies. The offspring of an alcoholic parent, even when raised by non-alcoholic parents, have a 4-fold increase of being alcoholic. Okay, so that shows you that there is some type of genetic disorder there. The offspring of non-alcoholic parents, when reared by alcoholic parents, did not have an increased risk of alcoholism. Pretty interesting. So it does show there is some genetic factors in there. It shows too that the individuals that have this ally, which an ally is a variation, are much less likely to become alcoholics. But if they have a variation of this, and you do not have to know these, okay, I want you to know that genetics do play effect on alcoholism. All right, schizophrenia. For those of you that are in our psych program, even for primary care, because a lot of times the mental health patients are going to come to you in primary care, and you're going to send them to our friends in mental health. So this tells you what I've already told you. If you have one affected parent, then that offspring is 10 times higher than the general population. It increases if there's a sibling. If an individual has 2 affected parents, then they're at 50%. Bipolar affective disorder, you can read those. Again, it goes up if they have a relative or if there's more than one person in the family. So read over these general principles of complex disorders. And looky here, genetic components can be altered. If we had talked about that in chapter 6, epigenetics. If not, if you're looking at this before class, we will talk about it in epigenetics, and it is so neat. It is so awesome how that can happen. So remember that most diseases have a genetic and environmental aspects. And treating a genetic lesion could mean prevention and treatment. So that's awesome. Genetics has come so far. I will put the link to this Kahoot, which is going to just help you with reviewing and self-study for the genetics. And don't forget, there is a quiz this week too. We'll talk more about that in class, or if you're listening to this after class, we talked about it in class. So go back and look at your notes. All right, guys, I will talk to you soon. Thanks.